I have 3 different spells. I've captured all of them. I can say this one's epileptic, this one's not. About 10 to 20% of people with epilepsy may develop non-epileptic events also.
Fellow Homo sapiens, today it is part and topic 2 of our conversation with the adult epileptologist, neurologist and fellow podcast host Michael Kentris from Ohio, US. And our title today is, Do You Actually Have Epilepsy? We talk about the diagnosis of the condition, how complex it can be, and how it is really important to know that diagnoses can change over time. To learn more about Michael, make sure that you check him out at torierobinson.com/epilepsy-sparks-insights, where you can find links to his work. And if you haven't already, make sure that you subscribe to the channel to receive weekly episodes featuring some of the world's leading epilepsy specialists and researchers.
Well, thanks for having me on again, Torie. I appreciate it. I am a clinical neurologist, epileptologist, and I practice at a community hospital. I talk a lot about neurology education on the Neurotransmitters podcast, focus on learning more about what are best practices in neurology and what you can do to help your patients.
Fab. And you are specifically an epileptologist, is that correct? It is your specialization in neurology.
Yes, it is. I do a lot of general neurology, but that is, I would say, one of my passions.
We were speaking briefly before this recording about functional neurological disorder, PNES, non-epileptic seizures, etc. Could you tell us a bit about your work in that, the relation between these type of seizures and epileptic seizures, and how you distinguish between the two?
You know, it's one of these situations where a lot of times someone comes in, to emergency and, you get a call, as the consultant. I got a patient here who had a seizure, the ER doc calling you up. And, a lot of times I keep this to myself. My first question mentally is, well, was it really, because a lot of physicians, a lot of clinicians don't necessarily accurately identify seizures based off of what we call semiology, which is just kind of the physical manifestations of what happens during an episode, whether it's epileptic, non-epileptic, etc. So there are certain clinical phenomenon that occur during an epileptic seizure. Obviously, that is a wide and varied, depending on what part of the brain is being activated, and can look like many, many different things, versus non-epileptic or a dissociative seizure, one of the types of functional neurologic disorders. And then there are, in addition to those, there's different types of like sleep, think of like sleepwalking as kind of the classic, but different type of sleep behavior disorders, or in folks with intellectual disability, you might get some sort of stereotyped behaviors, kind of like with different repetitive types of movements and so forth. So trying to drill down on your story in terms of what is going on, because I always remember what one of my teachers told me as a resident was, every seizure is like a story. It has a beginning, a middle, and an end. And you need to be able to tie those pieces together appropriately. It needs to make sense. It may not be something you're super familiar with, but it needs to make sense consistently. Otherwise, you're really questioning, well, do I really have the right diagnosis? If we think about, like, for instance, say, folks who have medically refractory epilepsy, right? So folks who have been on at least 2 different medications, who are still having breakthrough seizures, the recommendation typically is to get these folks to an epilepsy monitoring unit, get them off the medications, put them on the video EEG recording, and capture a spell. And, in the US, a lot of the data would suggest about 40%, depending on what study you look at, don't actually have epilepsy. So we are, a lot of times, we're anchoring our diagnosis too soon.
Yeah.
So maybe these are syncopal fainting spells, maybe they're these functional seizures, and we're treating these people with anti-seizure medications for years oftentimes.
Oh my goodness.
And, these aren't necessarily without risk, especially in younger people. And then in addition to just the medications themselves, right, people may be losing jobs. They're not able to be independent.
Can't drive anymore.
Tons of psychosocial consequences of this inaccurate diagnosis. So it's really important to get your story straight right from the get-go.
Yeah, question oneself, I guess, in terms of diagnosis. We were talking about this before, weren't we, about how, no matter one's qualifications and level of, the number of books you've read and or the number of years you've been on this earth, one must always question one's thoughts, beliefs, suppositions, and diagnosis.
I'm fortunate in as much at my new position that even though it's not, there's no neurology academic department, I still get medical students and residents from other services coming through. And I always tell them, like when you get a report from another clinician, just like trust no one. And I say, don't even trust me.
That's good.
You need to verify everything independently. It's, especially in big healthcare systems, you get this game of telephone going on. And so a lot of times I'll be going in to do a consultation with a patient in the hospital and be like, oh, they asked me to come and see you because, they said you were a little confused. And I'll be like, I'm not confused. And it turns out they're not. They're not actually confused at all. So I think, just having that frank and open conversation with your patients about what do they think's going on. And, if you're really lucky, you'll also have someone who is there who observed it from the outside, because, as a lot of your listeners probably know, if it was a seizure, a lot of times the memory of the event is very fuzzy at best.
Yeah, or non-existent sometimes.
Exactly, yeah. And there are some old studies, I think it's about 70% of diagnoses can be made from the history alone, right? In medicine, it's our most fundamental tool is just getting an accurate story. And a lot of times I always tell folks, if they are having recurrent events, everybody's got, a camera that they're carrying around with them. I should say most people. Just video record it, because by using that semiology, we can look, what kind of movements. Are the movements synchronous with one another? Are there side-to-side movements? Are the eyes open? Are they closed? Different constellations of symptoms say like, oh, this is very consistent with an epileptic seizure versus this is very suspicious for a functional seizure. And then that can really guide you in terms of what testing, like, should I be more aggressive with medication? Should I hold off until I can get more information? And really guide you in providing the best care for these people with these, events that are oftentimes very nebulous at the first onset.
So what would you do if you say, okay, this patient is not actually having epileptic seizures? You can't presume that they are not having epileptic seizures at all, because that's just one or two views or pieces of evidence of their behavior or movement at that time. So how do you go about ensuring that you don't diagnose somebody based on that one or two sources of information?
That is a great question, and actually is a fairly challenging one. So if you're, again, this kind of goes back to the stories, right? So one is, how many different types of events are there? And then you have to go through each one, get down into the real weeds with it. How do you feel beforehand? What's the first symptom that you feel? Do you feel anything? Is any warning? And, again, hopefully there is a close friend or family member who's observed most or all of these events who can be like, oh yeah, and then I see them do X, Y, or Z. And then you can kind of get the whole, isolated incident.
Right.
And they're like, all right, are there any other types of episodes that are happening? Just anecdotally, I remember during my fellowship, we had this one woman who came in, and she was with us for, I think, about 4 or 5 days. And we had caught multiple non-epileptic seizures. But the problem was we hadn't caught one of the event types that she was her entire EEG for days off of her medication was normal. And we were just about to discharge her home from the hospital. And literally hours beforehand, she had an epileptic seizure. And we're just like, geez.
We almost missed it.
Right, exactly. And so, because we hadn't captured that last spell yet. So you really need, and that's really the gold standard, is this video EEG documentation of, I have 3 different spells. I've captured all of them. I can say this one's epileptic, this one's not. Because as you're probably aware, about 10 to 20% of people with epilepsy may develop non-epileptic events also. And so then you got to go back to the drawing board, reevaluate, because then the question is, do I increase the meds? Do I need to focus on another avenue of treatment or evaluation? And I mean,
or encourage changes in, in lifestyle as well.
And it becomes very challenging when you have like these multiple moving parts now.
We're far too complex a species, aren't we? It's like, God, I wish we were simpler sometimes.
I guess it's job security for me at least. But
there is that.
I do wish at times that I wasn't quite so frustrated. It's like one of those things like, everyone loves a good mystery, but nobody likes a mystery that you can't solve.
Yeah, and that's such a really lovely, polite way to put it, especially from patient perspective. Yeah.
Right.
Often people's health changes over time, doesn't it? So you could be having, when I was little, for instance, I was having solely focal seizures, and then they became secondary generalized tonic-clonic. And I think, that is a really common thing, not necessarily that avenue, but how people's seizures change over time, over the decades, or sometimes smaller amounts of time. Do you think that's important as well, looking into that and keeping in touch with patients?
Absolutely. It's one thing. It's great, obviously, if you start someone on their first anti-seizure medication, everything's controlled, minimal to no side effects, perfect, aces, right? Unfortunately, that is not necessarily the majority of people with epilepsy. So over time, like you said, are we identifying all the seizures? Because there's certainly plenty of things where the person, especially if they live by themselves, may have focal seizures where, they don't have the big, grand mal tonic-clonic seizure. And so it never really comes to attention, either to themselves or to their physician or clinician.
Yes, it's no big deal, really. But no, darling, that is a big deal.
Or a lot of times, someone comes in with their first seizure and it's their first tonic-clonic seizure, and you're talking with them, it's like, oh, this person, they've been having like these panic attacks going on for years, and then you find out like, oh, maybe they got some mesial temporal sclerosis or another sort of structural brain abnormality right in the temporal lobe, and you're like, oh, they've been having focal seizures for years, and we're just capturing them now because now she had a car accident, or he fell down and bit his tongue or smacked his head and someone saw it. So it becomes this thing where you have to go back and ask I always say when I'm talking to people, it's like, I'm going to ask you some weird questions now. And because it's like how many doctors ask about like deja vu or like weird feelings in your stomach that comes up towards your head, I know I've gotten some looks from people in the past, but sometimes you get like this. And I always feel very validated, this like look of like, yeah, how did you know that? I'm like, just asking questions.
Sometimes, especially if the person in question is not necessarily familiar with the epilepsies, which most people generally aren't, right? And which is completely understandable. And if you ask them something which like rings a bell, like, oh, well, I kind of thought that was normal, but I knew it wasn't normal, and you're describing that to me, and yeah, that brings that bell, like, wow. And it's lovely to have, well, not necessarily lovely, but it's good to have that sort of recognized as a thing to be noted.
Right, because a lot of people is like, I just thought I was going crazy, but no, we know why this is happening, and we can hopefully do something to make it better in an ideal setting.
Yeah, and improve one's quality of life.
Absolutely.
That is what you are there for, is it not? And everybody in neurology and epilepsy, to improve quality of life, whatever that might mean, whether it's about reducing seizures and or improving mental health, physical health, all comorbidities. We were speaking about that before, the whole shebang. Thank you so much for being with us, Michael. It's been a joy, as it was last week. And no doubt we will have you again. Could you please just remind everybody the name of your podcast so that we can encourage them to go and tune in?
Yeah, it's called The Neurotransmitters, and it is available on all of your major podcast platforms, Apple, iTunes, Spotify, and so on. So please take a listen if you're interested, and feel free to reach out if you have any topics that you would like me to cover, or even if you want to be a guest.
And under this recording, you will also see links to Michael's profiles. You're on Twitter. You're around, aren't you?
I am around.
Thank you again for joining us, Michael.
Thank you so much.